Assalamu alaikum wa rahmatullahi wa barakatuh. Today, we will continue our lecture about 2022 American Society of Anesthesiology Practical Guideline for Management of Difficult Airway. We will talk about part 3, Preparation for Difficult Airway. وقبل ما أبدأ عايزة أقول حاجة، لأن أنا لسه داخلة على اليوتيوب أناليسز واليوتيوب ستوديو، بصيت على الأناليسز بصراحة جالي إحباط. يعني لقيت الواتش تايم من السبسكرايبر 60% والواتش تايم من النون سبسكرايبر 40%. طب أنا عايزة أسأل بقى سؤال بسيط كده، يعني ال 40% اللي مش عاملين سبسكرايب ولا مشتركين في القناة دول، يعني مش مشتركين ليه؟ يعني بتتفرجوا على الفيديوهات وفي نفس الوقت مش مشتركين. طب ليه؟ واتش تايم كتير، يعني معناها ان بتشوفوا فيديوهات كتير قوي في القناة. طب مش عاملين سبسكرايب ليه؟ بتكرهوني مثلا؟ ما بتحبونيش؟ يعني اتمنى يعني ما دام بتتفرجوا على الفيديوهات تشتركوا في القناة. يعني كل واحد بيعمل مجهود لازم يشوفوا الفيدباك بتاعته ويلاقي كده بوزيتيف فيدباك حلوة، يعني تديله حتى حافز يكمل. لان اقسم بالله انا بعمل مجهود، يعني ربنا وحده اللي عالم بيه عشان اطلع الفيديوهات كده واجمع الداتا بالطريقه دي. فربنا يكرم ويدينا الثواب يا رب باذن الله. واتمنى اتمنى اتمنى ال 40% اللي مش مشتركين، اللي بيشوفوا الفيديوهات دول ومش عاملين سبسكرايب، يشتركوا في القناه بليز. اوكي، ويلا بينا نبدا بقى. هنتكلم النهارده لبارت 3 preparation for difficult airway. Steps for successful intubation in difficult airway scenario. In order to improve your intubation skills in difficult airway scenario, you have to do what you need. You need to train well. You need to have or to attend simulating training courses for difficult airway management. And I think these courses become available everywhere. You have to practice to manage difficult airway in non-emergency situation in order to handle the situation in a proper way if you can't intubate, can't ventilate, or emergency airway scenario. Also, you have to know who you need, which person you need. You need to communicate with whom. This is what we're gonna know later. You have to, what you need. You should have what you need. You should prepare well. You should prepare all the equipment and person for difficult airway management. Also, you have to know what you need. You have to prepare for a plan for management of difficult airway. I told you, you have to prepare well and have a plan in order to prevent a catastrophe. So any airway provider should have a plan in place before induction of anesthesia or before starting airway management, difficult airway management. This should be discussed at the team brief and sign in face of the WHO surgical safety checklist. And I think I make a video especially for the WHO surgical safety checklist. You can go to YouTube channel playlist and find the patient safety video and the WHO surgical safety checklist. Before intubating your patient or managing difficult airway scenario, you have to answer or to find the answers for a lot of questions. For example, where are you going to do your airway intervention? You're gonna intubate your patient in operating theater, in the ICU unit, in emergency department, in the ward, or even out of hospital. Are you familiar with these locations? Especially in radiological unit. in the CT scan table and geographic table, this table didn't allow head-up position or elevation of the head of the patient for proper pre-oxygenation and proper positioning of the patient. Even it doesn't allow for anti-Trendelenburg position. You have to know who else is on your team, what their skill is, and also what about your skills. Are you qualified enough to handle difficult airway scenario or to intubate a patient with difficult airway or known that this patient with difficult airway? What equipment is available? Do you have all the equipment for difficult airway management? What about suction device? What if you want to bring an equipment or device from any place else? How long would it take to get this device in your hand? Can the patient be adequately positioned for airway management? What are you going to do if you don't get the tube? So you have to plan for the end at the beginning or before you start, because it's not allowed to take anything away from your patient that you can't replace. When I say so, I mean it's not allowed to give your patient neuromuscular blocker and abolish spontaneous ventilation or spontaneous breathing, and you don't know how to replace that, and you don't know how to ventilate your patient if you can't intubate him. This is not allowed. So, American Society of Anesthesiology 2022 recommendation for difficult airway preparation. They ensure, you have to ensure that airway management equipment is available in the room. They recommend that ensures that a portable storage unit for difficult airway management is immediately available. Also, they recommend if difficult airway is known or suspected, a skilled individual is present immediately available to assist with airway management. They recommend that you have to inform the patient or responsible person of the special risk and procedure pertaining to management of difficult airway. They also recommend to properly position your patient for intubation, which we mentioned in the previous video. Part 2 is a head-up position, sniffing position, a head-up position from 15 to 20 degree, sniffing position, the external auditory meatus at the level, maintained at the level of sternal notch. In obese patient, you have to put your patient in RAM position. American Society of Anesthesiology new guideline recommend administration or giving supplemental oxygen before initiating management of difficult airway. And they also recommend to continue to deliver supplemental oxygen throughout the procedure, including extubation. ASA recommend or ensures that at least a minimum monitoring according to the ASA standard for basic anesthesia monitoring are followed immediately before airway management, during and after airway management for all patients. So, in order to manage or properly manage difficult airway and prepare for difficult airway scenario, first step is to having an airway strategy. And I said airway strategy, not airway plan, because having an airway plan, it's to have a single approach for airway management. But to having airway strategy, a strategy is to have a coordinated logical sequence of plans in order to maintain oxygenation and maintain good gas exchange, decrease the rapidity of desaturation, and prevent aspiration. So airway provider should manage difficult airway through airway strategy rather than airway plan. They should decide beforehand what the algorithm is going to be, depending on what is available locally. Have a plan for intubation, have a plan for oxygenation, have a backup plan or even two for each intubation and oxygenation. Have a clear idea before starting what the locally available cricothyroidotomy kit, how it looks like, and how long it takes to set this up. You should have a plan and be ready to carry out that plan. Second step of preparation is preparation of the staff. Choose a competent assistant to assist with the airway. When I mentioned or when I said competent assistant is somebody who knows how to properly or to do cricoid pressure in a proper way, how to do backward, upward, rightward pressure in a right way. A good assistance. Also, you have to choose a competent assistant to give drugs and be familiar with the medication. You have to assign a staff member to act as access, somebody who can run all around and get the equipment or the proper equipment. Also, you have to inform standby staff to be ready. You need at least a senior anesthesiologist and ENT surgeon to be in a standby. You have to discuss the plan with the team. Every team member should know his role in a specific way. Ensure that everybody is aware of what is going to happen. For example, okay, team, plan A will be video laryngoscopy with bougie. Plan B with fast track. Plan C is second generation laryngeal mask or iGel fast track. You have to be specific. Plan C will be needle cricothyroidotomy or scalpel cricothyroidotomy. You have to be specific. Everyone in the team should know his rules. Third step in preparation is preparation of the equipment. Plan A, equipment should be ready for use. Plan B, equipment should be available within 60 seconds. And when I say 60 seconds, it means that this equipment should be available in the room, within the reach of my hand, wherever possible, unwrapped and lubricated. Drugs should be drawn up, including a couple of adrenaline ampoules in case of CPR scenario in rapid sequence, if you need to do CPR scenario in rapid sequence induction. The equipment should be checked and its operability should be ensured or must be ensured. For example, the CMAC batteries should be charged and well functioning. You should check for laryngoscope and its batteries, okay? Because here, as we all know, it's not like we all know. Time, we all know that time means money. No, here the scenario is different. Here time means life. Time means hypoxic brain injury, disability, brain death. Time is crucial. So ESA new guideline recommends that basic minimum content for the anesthesia location cart or trolley at least have self-inflating resuscitation bag, suction tubing and suction casters, and appropriate connectors, having various size of face mask, various size of oral and nasal airways, various size and type of laryngoscopic blade and handles, various size and type of tracheal tubes, tracheal tube introducer bougie for adult and pediatric patient. Also, they added tracheal tube stylet, malleable and rigid, equipment for emergency invasive airway management, various size of supraglottic airway device, including first generation, second, and even third generation supraglottic airway device. Having water-soluble medical lubricant, having nasal cannula and oxygen face mask, video laryngoscopy with appropriate stylets, the minimum standard ASA monitors, and have anesthetic induction agent maintenance and rescue medication should be available in the cart. So the most important is providing the right equipment in the right amount, in the right place at the right time. So having a clearly labeled trolley is mandatory. It serves as visual guidance and prompt one to move along a strategy if not making progress. Even you can add not only labeling the drawer, you can add color coded to make visual stimuli for the airway provider. The drawer of the trolley should be labeled and can be customized as required. It illustrates the particular type of equipment present in every drawer, and this specific make a model of equipment should be agreed locally. There should be a regular, comprehensive, and continued training provided for all relevant staff, anyone dealing with the airway. So, what does the ideal difficult airway trolley looks like? The ideal difficult airway trolley should compose of top service and 4 to 5 drawers. It should be mobile, firm, and strong, clearly labeled or even color-coded, as we mentioned before. Should be easily cleaned, stocked in a logical sequence, and the attached document include Difficult Airway Society or modified local guideline or ASA guideline for difficult airway guideline. Checklist for restocking and logbook for daily checking. This is the criteria of the ideal difficult airway trolley. So let's know now what to be or should be in every drawer. Top of the trolley should contain flexible intubating fibroscope, portable scope with battery light source, portable stock system, or single-use fibroscope as amboscope. The sides of the trolley should contain, as in the picture, contain bougie, adult and pediatric size, entry, intubation caster, airway exchange caster. Drawer 1 have equipment for plan A, which is bougie. Ideally, it's found in the side of trolley, short handle laryngoscope, McCoy blade and or straight blades, and video laryngoscopy. Drawer 2 have equipment for plan B. We will talk about the plan and the algorithm next video, inshallah. Drawer 2 should contain equipment for plan B, which is laryngeal mask or supraglottic airway device with different size, or second generation device, which is iGel, sleeper, intubating laryngeal mask with different size. Entry tubing caster, ideally it's found on the side of the trolley, as we mentioned before. Also in this drawer, we can find fiber optic adjuvant, or even we can put fiber optic adjuvant in a separate box, but this box should be attached to the trolley. Fiber optic adjuvant include Behrman, Ofisabam, Ofisabin airway, sorry for that, mucosal automation devices, fiber optic compatible angle connector, nasal sponge, 4% lignocaine, 10% lignocaine, Anesthesia, and co-phenylkine. This is the local anesthetic and decongestant. Drawer 3, sorry, should have equipment for plan C, which is various size face mask, various size oropharyngeal airway and nasal airway, laryngeal mask, a Brucel laryngeal mask with different size. Drawer 4 have also equipment for plan D, which is can't intubate, can't ventilate. God save us from this scenario. The equipment should be in drawer 4, large bore cannula, including quick trash cannula, scalpel with blade number 20, tracheal dilator or tracheal hook, bougie, which is in the side of the trolley, curved endotracheal tube size 6 and 7. This is the ideal trolley. And this is suggestion for drawer label, if you want to read them. We will talk about algorithm and plan in next video, inshallah. The fourth step in preparation for difficult airway is patient preparation. To get patient confident and cooperation, this is very nice thing. If your patient is conscious and can process this information, you have to explain to your patient the plan, what is the plan is. It's nice to get your patient in your side if they can process this information or the plan that you gonna discuss with him. This is very important. As I recommend to give supplemental oxygen before initiating management of difficult airway, at least a minimum 4 to 5 minute pre-intubation, by using low or high flow nasal cannula, face mask, or supraglottic insufflation. Continue deliver supplemental oxygen throughout the process, including extubation. Pre-oxygenation is a must. This is a crucial and mandatory, because brain this start dying within 5 or less than 5 minutes when if patient is apneic with no oxygen. Hypoxic brain insult and permanent brain damage start even before 4 minutes from with no oxygen and with apnea and no oxygen. Permanent brain death even start 4 to 6 minutes later. Did you see? That's why supplemental oxygen is mandatory. This is crucial. ASA didn't recommend routine aspiration prophylaxis for every patient. They recommend aspiration prophylaxis for patients at high risk of aspiration. As we mentioned in previous video, you can go to part 2 and listen to it. In patient preparation, we have to follow preoperative fasting guideline, which is 2 hours for clear fluid, 4 hours for breast milk, 6 hours for solid food, non-human milk, feeding formulas, and 8 hours for fried food and fatty food. In patient preparation, you also have to properly position your patient for intubation, as we mentioned before, and to take informed written consent. This is crucial in patient preparation, either from your patient or from caregiver, if your patient is unconscious or can't process the information. Pre-oxygenation, as we mentioned, is crucial. This is very important, especially in patient with unconsciousness or in emergency situation or patient critically ill patient in intensive care units. In normal patient, to do pre-oxygenation, you have to give oxygen supplementation with FiO2 100% or more than 95% for at least 4 to 5 minutes, or at least 8 vital capacities, deep breathing, 8 vital capacities. But the situation here is different in critically ill patient and in emergency situation, because in critically ill patient or emergency situation, these patients can't secure their airways. These patients may have lung pathologies, decreased conscious level. They can't secure their airway, increase oxygen demand, and decrease oxygen carrying capacity. Even decrease in respiratory drive. So these patients are more liable for rapid desaturation and hypoxic brain injury. So strategies to increase the effectiveness of pre-oxygenation done, especially for these patients. To improve or to give effective pre-oxygenation, it means that you prevent hypoxia, extend the safe apnea time, and decrease the rapidity of desaturation. This is the so-called NODESAT philosophy. In order to achieve NODESAT philosophy, which is increase oxygen and gas exchange, decrease the rapidity of desaturation, you can do it by several ways, either by CPAP, continuous positive airway pressure, or assisted ventilation. You can do it through apneic oxygenation or delayed sequence intubation. Let's know how each of these can be done in a proper way. You can make no desaturation and improve or give effective oxygenation through CPAP or assisted ventilation to increase mean airway pressure. Through bag valve mask reservoir, the ambu bag with beep valve, or manually assisting ventilation on a circle system or circuit system, or non-invasive ventilation by face mask. And as we all know, many ICU and anesthesia ventilator can do this in pressure support mode. Also, nasal cannula with high flow, such as high flow nasal cannula, can provide some sort of CPAP. Also, you can improve pre-oxygenation through apneic oxygenation. This is known from the apneic oxygenation. When patient is apneic, you continue delivering oxygen to your patient. This can be done during intubation attempt. You can do apneic oxygenation by Thrive system, modified laryngoscopy or oxygenation laryngoscopy, or through normal flow or low flow nasal cannula. Let's know each one how to do in a proper way. Thrive system, this is the transnasal humidified rapid-insufflation ventilatory exchange. This is the high flow nasal cannula. The idea is to mix the air, humidified, hot or warm, humidified air with oxygen. it allows insufflation of oxygen flow at high flow rate up to 70 liters per minute, combined with 7 centimeter CPAP, as we mentioned before. Normally or regularly, normal nasal cannula give oxygen flow at rate 10 to 15 liters per minute. This can be effective and well tolerated if it's given for short period, but for long period, this is give a dry air, which can be painful for some patient. Okay, you can either do apneic oxygenation through Thrive system, high flow nasal cannula, or nasal cannula, but for short period. Also, you can achieve apneic oxygenation through oxygenation laryngoscopy. Yes, oxygenating laryngoscopy. This is a laryngoscope modified to deliver oxygen through intubation attempt. I read in one paper about this, and they make a comparison. The result of this paper was published in Emergency Medicine 2021. The result was laryngoscopic oxygenation. Laryngoscopic give an optimal pre-oxygenation compared with high flow nasal cannula. Even it was better, but I read this in one paper only. Even they make a comparison between oxygenation, combination of video laryngoscopy with oxygenation laryngoscopy. They said that this improve oxygenation very much when adding or combining video laryngoscopy with oxygenation laryngoscopy. Oxygenation laryngoscopy, this is a modification of the blade at the front and back of the blade to deliver oxygen to the pharynx while at high flow rate while intubating your patient. First time to see comparison or comparison between high flow nasal cannula and oxygen modified laryngoscope for oxygenation during intubation attempt. And here is the reference if anyone want to see it. Okay. What about delayed sequence intubation? Delayed sequence intubation, this is a strategy especially for non-compliant, unconscious, or agitated patient due to the effect of medical condition or the presence of hypoxia. You have to understand that delayed sequence intubation is different from rapid sequence intubation. In delayed sequence intubation, we separate induction from giving neuromuscular blocking. We give induction or sedation without abolishing spontaneous breathing or without giving neuromuscular blocking agent. We can give a dissociative dose of ketamine or use any medication that optimize compliance without causing apnea, such as dexmedetomidine or haloperidol for doing delayed sequence intubation. In delayed sequence intubation, we need to optimize patient pre-intubation. We consider it as pre-intubation optimization. I need to improve pre-oxygenation before intubating my patient. I need to decompress the stomach with insertion of nasogastric tube before intubation. This is in agitated patient and uncooperative patient. Even if I want to improve the hemodynamic instability by giving blood, fluid, or inotropic support in agitated patient or uncooperative patient, I can use delayed sequence intubation by giving induction without neuromuscular blocking, then optimize my patient, pre-oxygenate my patient. It can be thought of as a procedural sedation, but actually no, it's not procedural sedation. This procedure is adequate pre-oxygenation and pre-intubation optimization, as I mentioned. The evidence is still limited to one prospective but observational trial which showed improved oxygenation without complication. So let's now know how ideally to do delayed sequence intubation. This is a guideline published 2011 and reviewed 2016 for delayed sequence intubation, which equal to optimize the hypoxic agitated patient pre-rapid sequence intubation. And we understand the difference between delayed sequence intubation and rapid sequence intubation. Our aim, as I told, is to optimize the patient pre-intubation, particularly in hypoxia or agitated patient. First, position your patient in semi-recumbent position, 20-degree head-up position. Higher, even higher, can improve or comfortable pre-oxygenation phase. In obese patient, put your patient in RAM position, maintain external auditory meatus at the level of sternal notch, put nasal cannula and non-rebreathing, nasal cannula at flow rate 10 liters per minute, and the non-rebreathing mask, you have to well fit the non-rebreathing mask, then consider the use of ketamine for agitation, or as I mentioned, any drug abolish the agitation and cause sedation without abolishing of spontaneous breathing. Start with ketamine. First, start with low dose according to your patient condition. Try 0.3 milligram per kilogram, titrated up to 1 milligram per kilogram, slowly intravenous. If indicated, consider gastric decompression by insertion of nasogastric tube, as we mentioned. Consider use CPAP for hypoxemia. Use CPAP if oxygen saturation less than 95%, aiming for increased oxygen saturation more than 95%, and use titrated B 5 to 15 centimeter water, depending on hemodynamic and oxygenation. Or you can use, as we mentioned for CPAP, bag mask ventilation with beep valve, 5 to 15 centimeter water. And as we mentioned in previous video, for optimal bag mask ventilation, you need to have two-hand mask seal, which is C&E, double C&E, or modified C&E, which is V&E. You can go to previous video, part 2, and listen to it. Optimal positioning for bag mask ventilation. Then wait and pre-oxygenate using CPAP for 3 to 5 minutes, or at least tidal volume, or 8 maximal breaths. But be careful in critically ill patient. As we mentioned, they can't take normal vital capacity or normal tidal volume. So better to use CPAP. You can optimize, as we mentioned, your patient pre-intubation. Consider other pre-treatment drug if you need for fluid, blood, need for inotropes or vasopressor to improve the hemodynamic. Then start induction with giving sedation, hypnotic, and paralytic agent. You can use here, after patient optimization, you can use neuromuscular blocking, which is better to use rocuronium in order to get the antagonist, which is the sugammadex. It gives the antagonist sugammadex in case of any complication occur. Try to wake your patient. And use apneic oxygenation to improve pre-oxygenation. As we mentioned, you can position head-up position of the patient to improve oxygenation. Use jaw thrust to maintain pharyngeal patency. You can add oropharyngeal or nasopharyngeal airway, as we mentioned in the previous video, part 2. And you can use nasal cannula at flow rate 15 liters per minute, or you can use high flow rate cannula at rate 70 liters per minute, up to high flow oxygen flow rate up to 70 liters per minute. Use humidified warm air with oxygen and high flow nasal cannula, as we mentioned. If needed, CPAP or bag mask ventilation with beep valve. Consider leaving on until paralysis, at least 45 seconds for the patient to get paralyzed. Then intubate your patient, and as I recommended, leave nasal cannula on through airway management period and even through extubation and post procedure. Always note that this guideline is not intended to be comprehensive guide. It shouldn't replace your clinical judgment. Always use your clinical judgment. No single recipe fit everyone. All patients should be optimally prepared pre-intubation. Consider contraindication to the various elements of delayed sequence induction, including cardiac respiratory arrest, spinal trauma, facial trauma, and severe head injury can do delayed sequence intubation. Consider possible complication of this technique, which is you can, when using CPAP, you have the risk for aspiration and gastric distension. Ketamine may cause increased intracranial pressure and laryngospasm. You have to put all these in your mind before doing delaying sequence intubation. What after intubation your patient? If I'm trying to intubate your patient, you have to confirm for tracheal intubation. As a new guideline recommendation for confirmation of tracheal intubation, you have to confirm tracheal intubation by using capnography or end-tidal carbon dioxide monitoring. This is the first recommendation. If you are uncertain about the location of the endotracheal tube or the trachea tube, as I recommend either to remove it and attempt ventilation or use additional technique to confirm your position. We confirm endotracheal tube position first by end-tidal CO2 monitoring. Also, we can confirm positioning by visualization of the endotracheal tube entering between the two vocal cords, or as I recommend, any technique for visualization. Either use flexible bronchoscopy, ultrasonography, or radiography. Also, auscultation of the axilla, confirm of air entry, auscultate epigastrum for no air entry. This is sign for endotracheal intubation. And as in the picture here, ultrasound, you can see the endotracheal tube in the esophagus and the other circle is the trachea. So this is esophageal intubation, not endotracheal intubation. We will stop here and continue algorithm for anticipated or unanticipated difficult airway scenario next lecture إن شاء الله. أتمنى تدعوا لوالدتي بالرحمة والمغفرة وجنات الفردوس الأعلى هي والدي. أتمنى تدعوا لي أنا كمان بصلاح الأحوال. والله ما تعرفوا الفيديوهات دي عشان أعملها بتاخد فعلا مني مجهود قد إيه، لأن أنا عادية زيكم، يعني أنا معلوماتي زيكم. أنا try بالفيديوهات دي try to improve الاكسبيرينس بتاعي وأراجع معلوماتي وأحسن من معلوماتي أكتر وأكتر معاكم. فأتمنى تدعوا لي، تشتركوا في القناة وتدعوا لأمي ووالدي. والسلام عليكم ورحمة الله وبركاته. أشوفكم بقى إن شاء الله الفيديو الجاي.